Or sometimes I hit this one button on my thing accidentally and it makes people not hear me, so.
Uh-oh.
Hopefully everyone else shows up. I wasn't sure how long that testing thing was going to take, so I think we're all good now, so. Okay, it looks like we got about 7 of us, maybe.
Our test for this class is next Friday, right?
Yeah, hopefully we'll actually get to do it. They wouldn't give me a straight answer in that thing. Did you hear me ask her when we're
Yeah.
going live? So we'll see. Hopefully later today I'll find out something. Okay. So anyway, I'll just give another minute or two here before I get started. If, obviously if this shuts off, we'll come back on and finish up. So for today, we had like 3 different chapters we were supposed to go over. So sleep and rest, thermoregulation, and sexual function. So I don't know if you guys noticed on the discussion board, I put some things on there about that for this week. So if you haven't been on the discussion board this week, make sure you get on there and answer some of those questions. Even if we don't get to talk about a whole lot of stuff like we would normally in class, at least you can kind of talk with each other that way, and I can kind of get in there and make comments here and there. So hopefully that helps you a little bit. Okay, so with sleep and rest, with this chapter, we kind of have gone over some of the stuff before. We just had some of that stuff in your other class. So I'm just going to point out some things that I think are a little bit more important for you to remember out of this chapter, and then we'll kind of go on from there.
Okay.
So chapter 24. So with this, just like with all the other chapters, towards the beginning of the chapter, there is a spot where it talks about age-related changes and functional consequences and all of that. So I'm going to tell you some of those. So some age-related changes that have to do with sleep. Let me get to this. Here we go. All right, so one of the things would be decreased time in deep sleep. So we all are familiar with how, when you are sleeping, hopefully everyone gets to that REM sleep, that REM sleep, because that means you're in a deeper sleep and you get more rest that way. So with older adults, they have decreased time in deep sleep. So they don't get to that point and they get woken up really easily. So they don't have that really deep sleep. Another thing with them is they take more time to get to sleep themselves. So increased time in light sleep. And then the third thing is decreased time spent in dreaming. So some of the negative functional consequences that will go along with this then would be, hey, it takes more time for them to fall asleep. They frequently get aroused, meaning that, the littlest sound will wake them up. Increased difficulty returning to sleep. So if they do get woke up, they have a harder time falling back to sleep. They have poorer quality of sleep. And they spend more time in bed without sleeping. Like they're just laying there and they can't get to sleep. So those would be some of the negative functional consequences. And then that part in the chapter also talks about some risk factors that would put people at risk for, problems with sleeping, basically. So some of those things would be pain. So if I'm in a lot of pain, I'm going to have a hard time sleeping. If I have nocturia, where I have to get up in the middle of the night to go to the bathroom, that's a big thing. Anxiety and depression. If you're really anxious or you're depressed, sometimes you have a hard time with sleeping. And with depression, sometimes you'll sleep more than you should because you're so depressed. Adverse medication effects would be another one. and then environmental factors. So if your room isn't quite like you want it for sleeping, like, you know how we like the blackout blinds and we like it to be nice and quiet and the temperature to be kind of a little bit on the cool side, those types of things, you know, affect how you sleep. So those would be risk factors. On this slide, it talks about the circadian rhythm being like a biological clock. So basically, we all have kind of a normal sleep-wake cycle. So this means that, you know, an adult would just become sleepy between a certain time of night. So typically between 10 p.m. and 12 p.m., people usually get really sleepy, like they need to go to bed. Then usually we'll wake up between 6 a.m. and 8 a.m. So as we age and we get older, older adults become sleepy earlier. So I don't know if you know anyone who does this, but a lot of people will go to sleep super early, like maybe 7 p.m. even. So they go to sleep earlier and they awaken earlier. Like my parents do this right now, which is crazy. They'll get up at 4 in the morning, and it's like, what are you doing? But they wake up then, and they're totally, you know, ready to go for the day at 4 a.m. Okay, so this talks about some of those risk factors that can affect sleep that we kind of mentioned a lot of them already. Again, you know, with environmental conditions, you know, if it's really noisy, it's hard to sleep because there's so much noise. Lack of privacy is another one. So like if you're in the hospital and you have a roommate, you know, maybe you can't sleep because you have someone in there with you. You don't have enough privacy. Pathological conditions can also make a difference with how you sleep. So people who have obstructive sleep apnea, they don't sleep well, right? So if they have a sleep apnea machine like a CPAP or a BiPAP and they actually wear it, then maybe they'll sleep better. But like my mom has a CPAP machine and doesn't wear it like she should. So she wonders why she doesn't sleep well, you know? Then this also mentions restless leg syndrome. So I do want to talk a teeny bit about that. Restless leg syndrome is just this irreversible urge to move your legs, which is often accompanied by unpleasant sensations in your legs. When people have this, it can affect both initiating sleep and also maintaining sleep. And usually the symptoms are not due to some other condition. So like if I have diabetes and I have neuropathy, that's different than restless leg syndrome. So people who are at risk for this would be people who have iron deficiency, people who have chronic renal failure, people that take a lot of different medications and maybe have adverse effects from those. And then the book also says that people who have this have an increased risk for anxiety and depression. Some of the things that we can tell people, you know, to do for this, you know, it's not really a well understood condition, so there's a lot of conflicting information out there, but they say if you avoid caffeine, sometimes that can help a little bit with this. All right, another thing I want to mention real quick is something called nocturnal myoclonus. So myoclonus is MYOCLONUS. So this is periodic limb movements during sleep. So this isn't just your legs, this could be anything. So during this, you have these brief muscle contractions that are spaced at certain intervals. So like you could have these muscle contractions every 20 to 40 seconds. So they could cause you to have leg jerking or rhythmic movements that you do. And sometimes you could see people do this more than 200 times a night. So you could imagine if you had something like this going on, you probably wouldn't sleep really well because you're doing this, right? So this can contribute to complaints of insomnia, frequent arousals, increased daytime sleepiness. A lot of time when people have this, it's associated with increased cardiovascular risk factors. So they may have issues with their cardiovascular system. Some people may not realize that they have this, but then if they go get a sleep study, they'll see them doing this during the sleep study. So then that's kind of how they're made aware of it. Okay, so then this gets into functional consequences affecting how we sleep. So again, we said that older adults take a longer time to fall asleep compared to younger adults. So they have a frequent times that they get up during the night for different things. So they get woke up really easily. They have a diminished quality of sleep. So they don't get to that deep sleep like we would all want to. So when you don't sleep well, there are some health consequences that you can have. You are at increased risk for stroke, cancer, obesity, diabetes, depression, metabolic syndrome, and substance abuse. And it can also affect your cognitive function. And again, you know, this gets into a little bit about pathologic conditions that can affect your sleep. So we already, you know, mentioned obstructive sleep apnea, but there's some other things that they mentioned here too. So like insomnia, you know, I don't know if you guys have ever had an episode of that, but it can be awful. If you can't fall asleep, you just feel horrible, and it totally affects like how you feel the rest of the day. So there's certain criteria that you have to meet for it to be considered insomnia. So I would encourage you to read a little bit more about that, because that definitely will affect people negatively. So when we're assessing people's sleep, some of the things we might ask them would be, how do you awaken in the morning? Do you feel rested? After you fall asleep, how many times do you wake up during the night? Do you feel drowsy or sleepy during the day? Do you take any medications to help you sleep? And you know, that's just a few. There's a few other things you could ask as well. There are some evidence-based tools that you could use to assess someone's sleep patterns. So there are a couple of sleep tools that they mention specifically in the chapter. There's one called the Pittsburgh Sleep Quality Index. This is going to assess the sleep quality and patterns over the past month. And then there's another one called the Epworth Sleepiness Scale. This focuses on daytime sleepiness over the past week. So as far as diagnoses that you could use for this problem, of course, you know, readiness for enhanced sleep. So if someone actually says to you that they're willing to explore interventions that can improve their sleep, this would be perfect for them. If someone has a disturbed sleep pattern or sleep deprivation or something like that, you could use any of these. So then this gets into some things that you can do to try and help, you know, as far as goals and interventions. So we want to do some interventions that help improve sleep. So some of the things that the chapter mentions are, doing certain types of exercises like Tai Chi. Um, that kind of has a little bit of a couple of things mixed in with it. So not only do you do exercise, but you also do some relaxation type things and meditation and stuff along with it. You could do listening to soothing music. You could put earplugs in so you don't hear a bunch of noise if you have a bunch of noise around you. You could do massage therapy, acupuncture, muscle relaxation techniques. And then a lot of times people take melatonin now. Does any of you know anyone that takes melatonin?
I know somebody at my job, they take it.
Do they
They
like
said,
it?
yeah, they said that they take it like 30 to like an hour before they want to go to sleep, and then it helps.
That's good. So when I was a nurse, they used to have different sleeping pills that we would give to people. And so many sleeping pills have so many different weird side effects. And so anymore, if you have to give someone something for sleep, they would rather you do melatonin instead of some of those sleeping pills. Have you guys heard about some weird things that have happened with people when they take Ambien?
I don't know what that is.
Ambien's a sleeping pill. And actually, you could probably Google this and look it up. But when you put this in a search engine, it'll come up with a ton of different weird things that people have done while they're on Ambien. There's a lot of like lawsuits out there where people say they took Ambien and then they ran someone over with a car, or they sleepwalked and did something crazy that they don't remember, There's a lot of weird stuff out there that people do on those. Okay, so then when we talk about nursing interventions for sleep wellness, some of the things that we would do, we would try to improve sleep for older adults in institutionalized settings. So do you guys notice this in some of your workplaces where they have a certain time that they turn the lights down and they make it like a quiet time where you shouldn't have any noise?
I don't know. I work in the morning, so I don't know what time they do all that stuff. But we have like different exercises classes that like they turn like the lights down low and like have like a calming type thing.
Okay, well that's good. I mean, that's still helpful too. A lot of hospitals will do this now. So if you work night shift at a certain time of night, they will automatically turn all the lights down in the hallways. They sometimes will shut people's doors. They'll have a sign posted about being quiet at a certain time. Other things that we can do, if people have sleep disorders like, sleep apnea, we're going to encourage them to use their machines, so their CPAPs and BiPAPs and whatever they need. If there's, an area where it's kind of loud in your hallway where you work, then maybe make sure that you give the patient earplugs or you close the door. Try to mask the noise, maybe with white noise. Do you guys know anyone that does something like that?
No.
We actually bought a machine not too long ago here at my house. It's just this real tiny little machine, and it has probably 18 different noises that you can program it to do. And it's just to like drown out people who snore around here at my house. So
Oh, wow.
like, there's a sound that sounds like ocean. There's, just like calming different sounds that you can play. So that's something that you could do as well. All right, so that's kind of the gist of this chapter. I would really focus on some of those different sleep disorders and then really focus on, the functional consequences of not getting good sleep and like the age-related changes. That would be the big thing out of this chapter. Okay, so another thing is, let's see. Chapter 25 is that thermoregulation. So let's see if we can pick out some stuff out of that. Okay, so when we talk about thermoregulation, we're talking about our body's ability to maintain a stable core temperature. So older adults are really at risk for, not being able to maintain a good temperature. So like they can have hypothermia or hyperthermia real easily. So that's kind of what this chapter is really focused on. So let's talk about age-related changes. So there's quite a few different age-related changes related to this. One of the things is decreased subcutaneous tissue. So if you don't have a lot of fat tissue, typically you're not going to be able to maintain your temperature really well. So you're going to be really cold really easily. Another thing would be older adults have decreased shivering. So when they're cold, you don't necessarily see their body doing that. They don't like shiver like you or I would. So what happens when you shiver? Shivering just causes you to try and like warm yourself up by doing that. So older adults don't have that, so they're not able to do that. Another thing with older adults is they have the decreased ability to acclimate to heat. They have decreased sweating. And they also have a decreased peripheral circulation. So this causes them to have inefficient vasoconstriction. So if older adults have this decreased ability to acclimate to heat, what do you think that means?
Is that like their body won't, like, if it's hot and they're cold, they won't get warmer or something like that?
So if it's hot outside, they have a harder time like cooling themselves off, I guess you could say, so they could overheat really easily. And then like they already have decreased sweating. So when we sweat, we kind of cool ourselves off in a way because we're getting rid of some of that fluid, so they don't have that ability. So they're very at risk for some of these different temperature changes just because of that. Okay, and then there's at least 3 different negative functional consequences that I want you to remember. So one of them is the ability to respond to adverse temperatures. So again, if it's super hot, the older adult has a harder time like cooling themselves off and like controlling their temperature so it doesn't get too hot and they don't get overheated. Increase susceptibility to hypothermia or hyperthermia. So again, they have a harder time controlling their temperature, so they could be like extremely low or extremely high real easily. And then the third thing would be a decreased febrile response to illness. So when you or I get sick, we have a fever usually, and that's associated with that. So like say I have a UTI, I'll probably have a fever going along with it, and I'll know something is wrong because of that. Or if I get pneumonia, maybe I'll have a fever. But with the older adult, they don't necessarily show like that. They have those atypical presentations of different things. So sometimes you just may see confusion and you don't see any of those other things. Or if they do have a little bit of a change in their temperature, it's only going to be really slight. Like maybe they're 99.8 or something instead of 101.5 or something. And then with risk factors, things that could make them more at risk for temperature issues. So age, you know, the older we are, the more at risk we're going to be for that. Alcohol and medications, adverse environmental conditions, and then also diseases like endocrine diseases, cardiovascular diseases, and also neurologic disorders. So there's some kind of question on this next test about something about like you're in a nursing home facility of some sort, and then it talks about like how you accurately maintain a temperature in that facility because of all of these older adults that you have. So you always want to make sure that you have an accurate thermometer so that you keep it at a certain temperature, because you know they have a hard time controlling, you know, being too cold or being too hot. So older adults usually prefer the environmental temperatures to be about 75 degrees Fahrenheit. Okay, so with risk factors, because older adults have a decreased heat production, they're going to be at risk for hypothermia. So you definitely need to know some specifics about hypothermia, but I'll get to that on another slide here. So they have a lack of a fever like we were just talking about, so sometimes it's harder to pick out when they're really sick because they don't show that way. And then this talks about medications and alcohol. So with alcohol, you have an increased risk for heat-related illness by inducing diuresis, because alcohol will make you pee more, so you can be really dehydrated from it. So you're going to have an increased risk for, you know, hyperthermia because of that. With medications, they can predispose this person to heat-related illnesses too. So again, if you're taking like diuretics, that's going to affect that. Okay, so with risk factors that affect, you know, your temperature regulation, if you don't take in enough fluids, which older adults are all like that, you're going to be more at risk for heat-related problems. And then just think of all the poor homeless people out there that are older adults. You know, they may not have somewhere to stay, so they constantly take all of their stuff with them, and sometimes they're dressed in multiple layers because they have nowhere to put that stuff, so they just wear it. And so they could be at risk for like being overheated and stuff. And then, you know, of course, when it's cold, you know, they have a hard time maintaining their heat in their body anyway, so they would be at risk for hypothermia as well. Okay, also, one thing on that last slide I forgot to mention, when it talks about cognitive issues. So if someone has dementia, they may be at increased risk for problems with their thermoregulation as well, because they may not wear the proper clothing to adapt to this. So sometimes you'll see them wear something that's totally inappropriate for the weather. All right, on this slide, it talks about lack of knowledge regarding normal temperature for older adults. So for example, when you use an air conditioning or heating system, sometimes people will not use that as a cost-saving measure. So younger adults may be able to adjust to the moderate heat or cold temperatures, but the older adult is not able to adjust to it. So even though maybe they are not using it because, you know, they're trying to save money, it's not always going to be a good thing for them. All right, and then this gets into the functional consequences again. So this is where I want to talk a little bit more about specifics about hypothermia and hyperthermia. So hypothermia, so when your temperature is really low. So in early stages of this, older adults will probably not shiver, because remember we said that's a change that they have. Sometimes they don't even complain of feeling cold in the early stages of this. So it's going to start to progress, and it's going to cloud their mental function. So they're going to start getting confused. So this can progress pretty quickly after the core body temperature falls to 93.2 degrees Fahrenheit. So you already have, because this is an older adult, you already have a diminished ability of your kidneys to conserve water. And, older adults commonly don't take in enough fluid, to help with this as well. So if you don't reverse this process, you can die from this very quickly, and it's going to affect your cardiac system. So anytime you would have a question about someone with hypothermia, you want to make sure that you assess their core body temperature, because that's what we're most concerned about, is that core body temperature. So prolonged exposure to environmental temps that are less than 68 degrees Fahrenheit can cause hypothermia. So what do you guys think would be some ways that we could warm someone up if they had this? Like, say they were a homeless person that was outside for a long time and got hypothermia. What would be some things that we could do to warm them up?
Like a heated blanket or something?
Yeah, so they have something called a bear hugger that maybe, I don't know, maybe you'll get to see eventually in one of your clinicals or something. But a bear hugger is like almost like a plastic type of a blanket that's hooked up to this machine that blows this warm air into it, and it'll help warm this person up. So that could be something you could do. What else could you do?
You can run warm fluids through them.
Okay.
It can either be like you can have them drink like warm water, not necessarily completely hot water, but something to kind of get them more acclimated a little bit easier.
Right.
So it's not like a shock.
Right.
I know we also have like an Arctic Sun. We have one of those too.
Explain what that is.
An Arctic Sun, it kind of uses it's this machine, and it's like there's these pads that go around the thighs, and we have them, and it's connected to this machine, but it's either heated water or it's cooled down water. But we can set the temperature of where we want it to be. So if we need them to be warmer, we'll set it to the normal temperature in Celsius, and it'll warm up to that temperature. And if it goes below anything, if it goes below that temperature, it'll heat the patient back up with the machine. And then if they stay at that temperature I think we keep it on them for an hour after they stay at that temperature, like consistent, and they stop going below the temperature, then connect it to see if they can stay at that temperature by themselves.
Okay. Yeah, so there's quite a few different things you could do really to warm someone up, but I would definitely encourage you to read more about hypothermia and how, like, the best way to take care of it so that you're going to do it in an appropriate way to help this patient. So the other thing I want to talk about real quick, because I only have a few more minutes before this cuts me off, and just please go back to your Canvas for a second in a minute here when this cuts off, and then I'll repost another meeting to come back into to finish up. But anyway, heat stroke and heat exhaustion So heat exhaustion then would be something that happens gradually from depletion of fluids, sodium, or both. So this can occur in active or immobilized older people who are dehydrated or underhydrated and exposed to hot environments. So like think of someone who maybe lives in an apartment and they don't have air conditioning and it's really hot outside. So they may end up getting heat exhaustion because they can't cool themselves down easily enough.
I had a question. You said
Yeah.
it happens gradually by what?
Yes, so it happens gradually from depletion of fluids. So hey, they're sweating and they're getting rid of all of these extra fluids in their body. And then also it could be just from immobilized people who don't do a whole lot, or it could be from people who just don't drink enough and they're in a hot environment. So that would be heat exhaustion. And then heat stroke is going to take it to like another step further. So heat stroke can occur in immobilized older adults in hot environments. So it progresses from heat exhaustion. So like you could start at heat exhaustion and then if it gets worse and you don't fix it, you'll go to heat stroke. So what happens with this is people get a lot sicker. They don't have the sweating ability, so they if you actually like felt their skin or tried to take their temperature, it's just super out of control. So the best thing to do for someone in one of these two things would be to get them out of the sun, like if they work outside or something, get them sitting in shade, or get them into some cool air or have a fan on them or whatever to try and cool them down. What kinds of other things could you do to cool them down?
Like a cold washcloth to the back of the neck, to the forehead, on top of their head. Just trying to give them some water, trying to give them a little bit, yeah, just cold water and like some cool washcloths.
Okay.
At least.
So again, you know, heat stroke is going to be to the extreme. So it's going to be worse than heat exhaustion. So you would start with heat exhaustion first, and then if it doesn't get treated well enough, you'll move on into heat stroke. And you can die from that. So your temperature just gets too out of control, and it's that core body temperature. It gets really high. So another name for, you know, just having like an out of control high temperature would be hyperthermia. So you get, believe it or not, those people, when they get to this point, they don't sweat anymore. You know, if they get so overheated, they just quit sweating altogether. So you have warm, dry skin, and it makes them more at risk for problems further. Okay, I'm going to stop right here and I'll call another meeting here in a second. So just go to your Canvas real quick and come back, because this is going to cut me off here in a second.